ensure the stent covers the entire lesion. The stent is usually fully expanded 1 to 2 days after the placement, so post-placement dilatation is not normally performed. Is a case of 65 years old male with lower esophageal cancer. This is the CT images. So here is lower esophageal mass causes proximal esophageal dilatation. This is coronal images. So lower esophageal mass causing complete occlusion of the lumen with proximal dilatation of the castor. We firstly pass the wire till the level of the stricture. Then contrast is injected to see the entry point of the stricture and assess the length of the stricture. Guide wire is passed to the stomach through the stricture. Then stent is deployed under fluoroscopic guidance, and dilatation may be needed or not according to the level of the dilatation of the stent after deployment. And this is the final imaging. See the contrast passing freely through the stent. Another case with mid-esophageal cancer causing near total occlusion of the lumen. Contrast is injected, shows the entry point and the length of the stricture. A stent is inserted and dilated with final imaging, show free passage of the contrast through the stricture and to the stent. This is a post-procedure instruction for the patient regarding eating and drinking. He should start with clear fluids, then soft food, take small bites, stay upright to eat, and stay upright for a last 30 to 60 minutes after the meal to prevent reflux. And he had to drink plenty of the fluid before, during, and after the meal, and the food should be moist enough for passage. And have to avoid some foods like tough meat, staying vegetarians, and crusty bread. Regarding cases of gastric outlet obstruction, it is most commonly seen in the patient with cancer of the pancreas, gallbladder, biliary tree, stomach, and the duodenum. And it has been reported that gastric outlet obstruction occurs in 15 to 20% of the patient with a pancreatic cancer. Stomach distension makes it very difficult to advance the stent delivery system to the target lesion because of loops that can be created by the guide wire and the delivery system in the distended stomach. To reduce this possibility of the looping, it is recommended that the stomach is decompressed with the nasogastric tube at least 24 hours before the procedure. A guiding sheath assist stent placement can help overcome this problem of guide wire looping, and the overall technical success rate was 98%, especially in the patient with a pancreatic cancer and duodenal stenosis. This is a case of 45 years old female with local advanced pancreatic cancer causing gastric outlet obstruction. CT images, axial and coronal CT, shows the stomach is markedly distended and dilated. So nasogastric tube is inserted 24 hours before the procedure to deflate the stomach. Here we see the nasogastric tube here. Contrast is injected through the diagnostic catheter to see the entry point and the length of the stricture. Then guide wire is used to pass through the stricture, followed by stent placement, deflation, and balloon dilatation, and the final imaging to see free flow of the contrast through the stomach. This is the CT image of the same patient, 3 months follow-up, show the stent in place, patent with average size of the stomach and no evidence of distension. This is another case of 87 years old female with a locally advanced pancreatic cancer. Here we see the level of the stricture, then the wire passing through the stricture, then after stent deployment, balloon dilatation of the stent, and finally contrast seen passing through the deflated stent normally. This follow-up CT images, coronal, sagittal, and volume rendering imaging show the stent in the place and patent with good flow of contrast through it. Finally, in the cases of colonic malignant obstruction, Standing, the incidence of colorectal obstruction between 7 and 29% among patients with colon and rectal cancer. Acute colorectal malignant obstruction managed surgically. However, emergent surgery in the patient with unprepared colon is associated with high morbidity and mortality. Moreover, in up to 30% of the patient with colorectal obstruction, curative resection is impossible due to distant metastasis, extensive tumor infiltration, or severe medical comorbidity. So placement of self-expandable metallic stent is preferred as a preferred minimally invasive and low-risk alternative to emergency surgery and has high success rate. Mostly in the patient with left-sided colonic lesion, mainly because right-sided cancer are usually managed via one-stage surgery without the need for bowel preparation or stoma formation. All the patient underwent cleansing enema before the procedure. After that, angiographic catheter was advanced over the guide wire via the anus up to the obstructive lesion. The length and the position of the obstruction were determined by injection contrast media prior to stent placement. When the opening of the structure was visible at 260 centimeter long, 0.035 hydrophilic guide wire was used to negotiate past the obstructive lesion. Once the guide wire was passed through the lesion, angiographic catheter was advanced to the most proximal point. Then super stiff guide wire was then inserted and the stent was placed over the super stiff guide wire using the delivery system. This is a case of colonic obstruction stenting. Here the stent through the obstruction and after deflation with the contrast passing through it normally. Complication of the stenting, two types of complication are seen. Major complication are defined as severe and life-threatening and include perforation, fistula formation, stent migration, especially in covered stent or post-chemotherapy with patient post-chemotherapy and hemorrhage. Minor complications are non-life-threatening and include mild pain, fever, reflux as an esophageal stent with it managed by using valved stent. Stent obstruction is the most common complication due to tumor ingrowth in uncovered stent or overgrowth at the end of the stent. Conclusion, fluoroscopic stent placement is a good treatment option for malignant GIT structure and obstruction because it is minimally invasive, safe, and cost-effective. Uncovered and covered stent each have their own advantage and disadvantage. The choice of the stent should be individualized according to the characteristic of the patient's structure and general condition. It can be done as a bridge to surgery by relief obstruction and allow oral intake before surgery, or as an palliative care in the patient with non-operable cancer. Thank you.
Thank you, Dr. Shady. Now, I have a question to Professor Hisham. I'm asking about your experience with glue embolization in post-traumatic pseudoaneurysm, either in the renal artery or in GTA. Because in our institute, usually we use histoacryl in treating such cases.
Well, yes, it is feasible. It's the choice of the umbilic material depends on what do you have and your experience that you have during the intervention. There's a clear shift now for liquid embolization, especially if the hemostasis of the patient is bad. But you know, cold sometimes is quite easy also to use and safe, and you could both. The most important is not what type of umbilic material you use. The most important is to achieve and to stop the hemorrhage. So if you're really comfortable with glue or with liquid, it doesn't matter, and especially in the kidney if it's a distal. In the GI bleeding, sometimes they've been reported that liquid may cause more ischemic lesions than colds, but yes.
Thank you. Any other questions from the audience?
Yeah. Question for the moderators and also for Ziga. What about proximal versus distal in splenic embolization? When do you do either one, or do you have a special technique or recommendations? And the second question, which is related to this, what embolic material do you use or do you prefer in each one?
That's a good question, and I think the way I approach it is I generally use plugs for proximal splenic embolization, and then if it's a hemodynamically unstable with a single area, like a pseudoaneurysm or just one area, I generally think I can get out there fast enough to use either some sort of liquid embolic or coil, and then you can also just do a I generally, if I do a distal, I don't do a proximal because I'm usually selecting a single area of injury. If there's multiple areas of injury, I think you just drop a proximal and get out. I avoid gel foam for all of those. For our partial splenic embos, I started using lava, which is basically like a little bit of onyx-like thing, and found that that's pretty successful with limited complications. I generally haven't tried that in trauma because I don't want to cause a splenectomy, basically. And so just try to be conservative with, if it's multifocal splenic injury, do a proximal. If it's distal, if I think I can get out there fast enough, just drop a coil or do a distal. I think the literature is kind of split if you look at different trials or basically like retrospective reviews. And so some will say favor distal, some will say favor proximal. I think if you split it up that way, I think it's worked out for myself. I'm open to hearing what other people are doing.
Is there any other question? I have a question for Shady. I did it right this time. Shady, so what's the advantage? So in Europe, I don't know how it's in the US, but the majority of those stents are put under endoscopy. They almost don't choose fluoroscopy. So what the difference for you is, and why it's better to use fluoroscopy than do it under endoscopy only?
No, regarding our cases, these cases already failed for passage of endoscopy first, or a patient is unfit for anesthesia or sedation. All these cases done without anesthesia or topical anesthesia, just topical anesthesia. So it is not an alternative to the endoscopy, but it is additional option in cases where the endoscopy is failed to pass or unfit for sedation or anesthesia.
So I have another question. So if it's easier and you can do it on local anesthesia on those very difficult patients, why not do it routinely in all patients? Because if you could do it in the procedure under local anesthesia, why go to general anesthesia? Because do it under endoscopy.
I think it is previously it was that was a trend that it is managed with endoscopy, okay, but start to refer these cases which is not fit for anesthesia to us, and we start to manage these cases. But if they send it from the beginning to us, it can be managed by this without any anesthesia or sedation.
Thank you. Great. Thank you. Any other question? I have one question for you, Najwa. You said now you have included the CTA in the planning of whenever you have a GI bleeding. So is it for upper GI bleeding, for lower GI bleeding? Do you do it before endoscopy or after endoscopy?
It's really for lower GI bleeding, because in the upper GI bleeding we do endoscopy first and not CTA or something else. So it's really for lower GI bleeding, because it's the real problem to identify and localize the source of bleeding. And when we don't have anything in the CTA, we can't go in the angio suite. So when we don't find anything, we check the upper if we have an upper GI bleeding. And we can do the nasogastric tube with the aspiration and lavage, because it can be very interesting. It's very quick, and we can see if we have a problem in the upper and not the lower. Sometimes we have some problems when we have we identify the source of bleeding in the lower GI, and we can't find it in the angio suite. And in this case, I don't know what we can do in this case. Because I know that some teams can provocate the hemorrhage, but it's very risky because we can lose patients with this provocation of hemorrhage.
Well,
So,
I have my friend Karim. He's
Yeah.
jumping.
okay.
Go ahead.
Being a very provocative person, I provoke everything. So why wouldn't I provoke the arteries as well? If I still do provocative angiography. I totally appreciate and understand the debate, but actually provocative angiography saves a lot of time if you are using glue, because I am here, the glue is ready. I'm not quite sure whether this or this is bleeding. We do provocation, it bleeds at once, and we inject it. So I know Hisham doesn't like this, and I've shown him a case that was over-provoked.
It doesn't mean I love you, Karim.
But you don't like the provocative.
I don't like it. I just say for the audience, it's not what is recommended. All the publication and all the literature is not recommended to do provocative, because they don't have a Karim Abdel Tawab in their cath lab every time. So,
Hisham, and personally, I lose a patient like this. I did heard this in a conference, and it was very, very risky, and we can lose patients with this. But if I'm asking for empiric embolization like we did in the upper, if it's a good alternative, and how we can do it, the empiric embolization, because you have already the source in the CTA. Is it a good alternative for this kind of cases?
a lot of publications, especially from France, from Dijon, from Romaric, is saying that empiric embolization, if you can identify the origin of the bleeding artery, is a good way to go. But it's very difficult to have like really great data to prove that. So most of the time we do it if we have a bleeding on the CT scan that we don't find, and we really identify it on the GDA. So we are doing it more and more, but we still don't have any large data to prove that's really, really effective. Especially if you have a patient that have bleed once, twice, third time, and he come back, and you don't have any solution, you probably it's a good way to go. But we do it in the upper GI bleeding, not in the lower GI bleeding, unless we see arteries. It's really have a bad aspect with like trunked artery or spasm or something like that, and it's in the region of the bleeding, so we go and we do it.
I just wanted to comment on the provocative tests. So I was a provocative person like Karim, so I used to provoke these arteries, but I one time provoked an artery with TPA, and the patient immediately started to bleed, and my catheter was far away. It was a lower GI. So with lower GI, I would just caution people so much, because by the time you get, because now you cannot do proximal, you have to be distal, otherwise you get complications. But trying to get distal, when that artery was profusely bleeding and the patient started to tank down, it was under anesthesia. So, and all the alarms started going off, and it was not a good experience. So, unless you are very close to where you think is going to bleed, yes, you can provoke, I think, but if you are still in this SMA and you're trying to find out which artery is bleeding and where is it supposed to be, I don't really recommend that, because some of the lower GI arteries are really very difficult to catheterize. Upper GI is very forgiving. I would just like empirically embolize some of the arteries. Lower GI, if I had to, like if the patient came down multiple times and we have a CT angio evidence that there is a bleed in a particular area, he came down once and angio was negative, so we didn't do anything. We give him another chance, maybe it just stopped. So we try again and he bleeds again. We try again, it's still negative. After two trials with negative angiograms, I've become more inclined to place a coil proximal just to reduce the pressure head into that segment, but not really go distal and empirically embolize an artery, because the chances of this being the right artery is, with all these vasorecta, is very difficult to really guarantee. But I put like and there's collaterals, so it's not going to cause ischemia, and it's a coil only, no particles.
Thank you, Ahmed. And I would just to say, if the patient's bleeding for the first time, I would say 50% of the lower GI bleeding stops by itself. So don't be very, very aggressive if it's a first time bleeding patient, especially if it's under coagulation. You should manage all the medical problem before going and jump and put him in an angio suite. Okay, thank you. Thank you all.